Next is Dr. Anish Sreedhar from Little Flower Hospital, Angamali. She is the senior consultant and she has got vast experience in oculoplasty for many years. Her talk is on lid malposition, repair technique and strategies. Over to you, ma'am.
I am going to deal with the usual entropion, ectropion. So first we'll deal with the upper lid entropions. Upper lid entropion is never involutional. There is a vertical shortening of the posterior lamella. The tarsus, conjunctiva, upper lid retractus is usually due to contracture. It's never involution. That is a quiz question. And the treatment depends on the thickness of the tarsal plate. If it's a thick tarsus or is it a thin tarsus? Thick tarsus, you can do a wedge resection or a tarsal fracture rotation. We don't do wedge resections nowadays. Tarsal fracture rotation is the fashion nowadays. Thin tarsus, you can do a lamellar repositioning. This is seen in Steven Johnson or Alkali Burns. So anterior lamellar repositioning, you are splitting the lid into anterior and posterior lamella. The posterior lamella at the gray line. The posterior lamella, the anterior lamella contains all the lashes, and the whole length of the lid, except the lateral and medial ends are split. And this is, you cannot use cautery because the lid is as you're repositioning the lid, it has to take up, so little a bloody surgery. And you can do a blepharoplasty. I am sitting at the head end of the patient, and the video is taken under a microscope. And as you shorten the anterior lamella, there can be a excess skin which can be cut away with a blepharoplasty. That is upper incision that you are seeing. And so the anterior lamella with the lashes are resutured at a higher position, and this is a post-op appearance. You need not put any mucous membrane graft, but I think if you have lashes in the posterior margin also, you can destroy them and put a mucous membrane graft, so that will not rub on the cornea. So you can see there is no lag of thalamus also. Tarsal wedge resection, this is a very old video actually. Here this is that you can use a cautery and shape a wedge with the base anteriorly, and then when you suture it, the lid turns out. That is a basic principle. That is a tarsal wedge resection. So nowadays what we do is we fracture the tarsal plate lengthwise, and you should take care that incision should be about 4 mm at least from the lid margin. You fully incise it so that you can see the orbicularis underneath. That is, you are fracturing the tarsal plate and then putting everting sutures. That's all. These everting sutures are taken out near the lid margin. So when you tighten them, when you tighten the sutures, when you tighten the sutures, the lid becomes everted. You can't fast forward it, I think. So when you tighten the sutures, the lid becomes everted. This is the one, all these entropions and ectropions tend to recur. So this is the one, I think, little bit for some years it stays like that. And cicatricial ectropion, if it is localized, you can do a pentagon excision. And if it is widespread, then you have to release the scar tissue and do a skin graft. Nowadays I don't go posterior auricular, I always take a skin. Even in small children you can take from the other lid. That is good skin match, and it's easy to take also. And what is floppy eyelid syndrome? Where the upper lid is so floppy that the lid opens when the patient lies down. So you have to shorten the lid and tighten the lid. This is done by a pentagon excision. The patient may complain when of lag of thalamus. Patient will not complain of lag of thalamus. Only dry eye, and on waking up the eye will be so dry. So you have to look for this and ask for this. Coming to lower lid entropion, it can be either cicatricial or involutional. So always differentiate between the two before you start surgery. So involutional entropion, the pathophysiology of involutional entropion is always asked as a short note. Here there is vertical laxity of the vertical lid retractors, overriding of the preseptal orbicularis over the pretarsal orbicularis. That is why you see a band underneath the lid. You see in the right eye of this patient. And there is interning of the tarsal plate, and it may or may not be associated with horizontal lid laxity. So how will you differentiate between the two? When you evert the lid returns to normal in involutional, but it returns to the inverted position in cicatricial. So this is a case, you have to look at the horizontal laxity by laterally pulling the punctum and see to which extent the punctum has been displaced. And the snapback test also, you can also measure the excursion of the upper lid, lower lid from the globe. The snapback test in the vertical laxity also has to be measured. So Jones plication is what we usually do. And what all do we correct here? The vertical retractor laxity is corrected by the plication of the retractors, lower lid retractors. The barrier of the suture prevents the overriding of the preseptal over the pretarsal orbicularis. The inversion of the tarsus is prevented by a suture bite through the lower tarsus, and the horizontal lid laxity can be corrected by a lateral tarsal sling or a pentagon excision. So this is the video. So you have to test always if there is a horizontal laxity before starting. The dissection is carried out from the subciliary line under the orbicularis. You can see that the cornea is shining through, it's very thinned out. Now bites are taken from the orbicularis of the lower part of the incision, plicating the lower lid retractors, 2 bites plicating, and then the small bite through the lower edge of the tarsal plate. You can have a gritty feel as you pass through the lower edge of the tarsal plate. 3 such sutures are placed, vicryl, 6 row. And if the end point of the dissection should be a slight eversion of the lower lid. If the lid is everted too much, that means, what does that mean? It means that there is too much of horizontal laxity. So then you have to do a lateral tarsal sling. The skin is then sutured. So this is a post-op appearance. Eye will look a little small in the early post-op period, but it's okay. This can remain as such for a long time. In acute spastic entropion, when the lid is inverted in an acute this thing, you can do lower lid everting sutures. Here the sutures are taken out, taken from the fornix through the conjunctiva and out through the lid margin, near the lid margin, near the lashes. So when you tighten them, the lid becomes everted. But this is a temporary phenomenon. You can keep the vicryl sutures there, but still it doesn't, you have to do a definitive procedure like the Jones later. Now cicatrician of the lower lid entropion. If it's mild, you can just do a levator. The lower lid retractor can be just incised and left as such. But if it is severe, you may have to do a replace that defect, that you have created with either a mucous membrane or some graft. So here I have incised the vertical retractors completely, and you can see the orbicularis in the depths of the incision. And now with glue, a mucous membrane which was harvested from the lower lip is placed there. Here too the immediate post-op, the immediate post-op will look good, but after some time it retracts to the original position. Involutional ectropion of the lower lid. So that is just, you have to tighten the lower lid. See this here, the lower lid is not, the tarsal plate is not attached to the lateral orbital margin. So you can do a pentagon excision or a lateral tarsal sling. So nowadays we always do a lateral tarsal sling where the lower lid is split into 2 layers, and the tarsal plate, both these layers are shortened and sutured separately to the lateral canthus. So cantholysis is being done. You strum and see where the lateral tarsal ligament is, and then cut it fully. Now we are splitting the lid into upper and anterior and posterior lamella. The posterior lamella contains the tarsal plate and the conjunctiva. So now shorten the posterior lamella till where you want it to be tightened. And then de-epithelialize the area where you have to bury it. And then pass double-armed 5-0 ethibond sutures. When you're suturing tissues under tension, always put a knot and then suture, otherwise it will cut through. So put a knot there and then pass it to the lateral orbital margin above the lateral orbital tubercle. I have overpassed, it's okay, I'll finish it off. I don't know how much. So, and then shorten the skin also. Okay, so I think this is the last slide. So this is a post-op appearance. This is a congenital ectropion. Thank you.
Thank you so much, ma'am, for that beautiful